So today I'll explain to you why active surveillance for intermediate risk prostate cancer is a safe and perfect option. Prostate cancer, a lot of press of overtreatment. Here are some articles from the Washington Post, the New York Times, Wall Street Journal, that a lot of men are being overtreated. A lot of men are exposed to the side effects of treatment, both sexual and urinary, when we intervene on them. And for most people in this room, they would say that, gosh, I can't believe what we're doing to people 30, 40 years ago, treating grade group 1 disease. The cure rates were excellent, but not a lot of those people needed that. And I have a premonition that if we fast forward 20, 30 years, we're going to be saying the same thing about intermediate risk disease and certainly unfavorable intermediate risk disease. Now, this is kind of a new concept. It's a timely concept, but it actually isn't. So this is a publication from 2012. It's the PIVOT trial, radical prostatectomy versus observation. And the study group was actually in the late 90s. This is really when PSA screening was coming to. 700 patients randomized either prostatectomy or observation after receiving a diagnosis of prostate cancer. And at 10 years, you can see that in this unselected group of patients, there was really no difference in terms of cancer-specific mortality or overall mortality. More recently, 2016, probably the best data we have for the management of prostate cancer is a study called PROTECT. It was published in 2016, New England Journal of Medicine, a more contemporary cohort, about 1,500 patients, 500 received observation, 500 received surgery, and 500 received radiation. And when we looked at these patients, these are the type of patients that we see. PSAs in that kind of 4 to 5 range, a lot of grade group 1 disease, but about 20% of patients with grade group 2 disease or 3, and clinical stage T1 primarily picked up on PSA screening. And when we look at these patients, including subgroup analyses, I'll draw your attention to this fact here. So over this 10 years, the number of patients that died of prostate cancers at 10 years with either surveillance, surgery, or radiation was 5, 2, and 2. So that's about 1%. So this is a good number to kind of keep in the back of your mind, I think, when counseling patients with prostate cancer, regardless. Important to note that over this 10-year period, that about 50% of patients had something change, whether that was upstaging, upgrading on a biopsy, patient or physician anxiety, clinical upstaging, that required intervention. And we are talking about active surveillance here. We're not talking about watchful waiting necessarily. So from these early studies, I would maintain that in unselected patients with intermediate or worse risk prostate cancer, intervening early is not associated with an improvement in outcomes, but it's important to note that a substantial number of patients will have something transpire over the next 10, 15 years that may cause us to intervene. Now, what about today? So over the second half of this talk, I'm going to demonstrate to you all how selection is key. So first off, intermediate risk prostate cancer, per all guidelines, is broken down into favorable and unfavorable intermediate risk. And I would say, as you're maybe dipping your toe into surveillance for intermediate risk prostate cancer, that we focus on the favorable intermediate risk patients. These are going to be generally grade group 2, otherwise known as Gleason score 3 plus 4 equals 7, PSA numbers that are generally below 10, and not a significant amount of core involvement. So this is kind of just a broad strokes guideline if you want to start out narrow, that we could perhaps focus on favorable intermediate risk patients. And then there's a lot more to it. So there's tumor volume, and we'll get into that a bit. This is a percentage pattern 4. So the key is really in the details here. Adverse histology, cribriform architecture, intraductal carcinoma. These are things that you really got to pay attention to. Genomic classifiers, I'll touch base on that in a bit. An MRI, what kind of value added does that bring? And then, of course, the patient comorbidity. If you've got an older sickle gentleman, you may be more inclined towards surveillance, where if they're young and fit, perhaps early intervention makes a little bit more sense. So now we're just kind of walking through the data. This is a very nice study done out of the Mayo Clinic, where they had patients that had biopsies, and most of these were intermediate risk, favorable intermediate risk prostate cancer, and then they went on to get surgery for some reason or the other. And when they looked at the predictive factors for either Gleason upgrading at the time of surgery or unfavorable disease, extraprostatic extension at the time of surgery, the reliable, predictable risk factors were increasing age, PSA density, which is really in the surveillance cohort across disease states been a very, very profound factor. So calculating that PSA density, and low PSA densities are typically going to be better. The percentage of pattern 4, so when you get that biopsy and you're looking at the number of cores involved and actually the specifics of the pattern 3 and the pattern 4, there's not really a perfect agreed upon threshold, but if you're seeing pattern 4s that are less than about 20% or so, you can typically feel a little bit better about that. And then the overall core involvement. So if they've got 11, 12 cores of grade group 2 disease, that's pretty different than 5% of a single core or a couple of cores with 10, 15%. So these are going to be some of the things that we really want to dial in on when we're looking at the biopsy. Then adverse pathology. So our colleagues on the pathology end of the spectrum, I think they've kind of accepted that there's a lot of information beyond just Gleason scoring that can help us. So cribiforming architecture and introductive histology, these are pathological features that are generally associated with upgrading and upstaging at the time of surgery. If you see these types of factors, that may not be a perfect patient for surveillance. Hereditary germline considerations, Dr. Kane kind of talked about this earlier. The incidence in this population would be low, on the order of about 3 to 5%. But if they do have it, there has been data suggest both in the early stage surveillance cohort as well as in other clinical scenarios that you have a higher rate of more aggressive disease. And specifically, these are going to be BRCA mutations, both 1 and 2, Ashkenazi Jewish ancestry, and then mutations in DNA damage repair. What other information can we glean? Molecular classifiers, and there's a host of them, and we certainly thank some of our sponsors for being here today. Here's just an example of one. This is a genomic test called the Veracyte test Decipher. And you can see here that when you look at intermediate favorable risk patients and you actually look at the gene expression signatures, some proportion of those are going to kind of group more with low risk patients, and then some are going to be a little bit more of an enriched for a higher risk cohort. Similarly, among unfavorable intermediate risks, some of those are going to behave a little bit better and some could behave a little bit worse. And similar type of data can be extracted from Prolaris, Oncotype, Decipher, whichever test you typically like to use. MRI features. So if we're going to embark on a surveillance program, I generally would say that we want to image the prostate, look for any masses or lesions that are concerning, larger tumors, extraprostatic extension, and then you get a very accurate assessment of the size of the prostate. So for instance, in this top MRI, which is from a real patient of mine, you can see there's a very pristine peripheral zone, no concerning lesions. On this bottom MRI, you could see a pretty nasty looking anterior lesion with some evidence of extraprostatic extension. And the MRI has quite good negative predictive value for high-grade, high-stage disease. And this helps us get away from some of the undergrading and understaging that we worry about. And so these are my opinions. These are the data. Then what do the guidelines say? So this is our very own AUA guidelines. I'll read you statements 11 and 12. In asymptomatic patients with prostate cancer and a limited life expectancy, clinicians should recommend watchful waitings. So these are going to be our older, sicker patients. In my opinion, that's kind of a no-brainer. But importantly, for patients with favorable intermediate risk prostate cancer, patients should discuss surveillance, radiation, and prostatectomy as well. This is level 1 evidence coming from the PROTECT trial. So in conclusion, active surveillance is a guideline-directed option for patients with intermediate risk prostate cancer. It does require a careful, diligent, personalized approach with attention to details, and those details are going to be patient comorbidities, the disease features, the molecular features, and then ultimately engage in shared decision-making. Thank you so much for your attention.